Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we are going to be doing our first interview of this season.
And who other to start off our new season with someone who's been listening from the beginning? Caroline Davenport.
Yes, that's true. Long time listener.
Yeah, it's only taken 5 years to get her on the podcast.
So Caroline graduated with her Bachelor's of Science in Athletic Training from Ithaca College. Then she received her post-professional Master's of Science in Athletic Training from Plymouth State University. She has previously worked at a private boarding school in New Hampshire, which I think that's really unique. Like, that's really cool.
And if you listen to, there are several stories that she has submitted on behalf of that private boarding school. So if you go back, you'll be able to hear some.
Something so unique. That's cool.
Mm-hmm.
But currently she is working at a family-owned chiropractic clinic in Vermont, whose primary focus is pre- and postnatal pelvic floor health, among other orthopedic conditions.
This is why it's so important to go into this topic, because this is not something that she's just seeing in a very focused clinic, but we actually talk about how this is addressed in sport, how she actually took this and created a screening process with her sport teams. And she said she was doing 30 people and 25 people in 30 minutes, that she's able to get this screening process out really quick, and how applicable it is for athletic trainers to put this into their practice. So we talk about what is pelvic tilt, complications of an excess pelvic tilt. We talk about functional versus just postural, different screening processes, of course, therapeutic interventions, and then lastly, just some rehab and stuff. So along with just some really great tidbits, this is a really actionable episode, which we try to get with just a lot of our episodes in general, but
make it actionable.
But I really think this is something you can walk away with today.
For sure.
Randy, let's get started.
All right, so no better way to start off an interview for the new season with some cryo breakers. So, Caroline, what made you become an athletic trainer?
So my first experience with athletic training was in high school. My high school athletic trainer was the East Coast famous Maria Hutzik, and she worked at Boston University for 30 years, had a vast experience there. She was the first female head athletic trainer there, and she was my high school athletic trainer after that. So she had a program for students and kind of took me in and exposed us. We got to observe under her, and she really let us kind of practice on each other. And that's really kind of where I fell in love with athletic training and haven't looked back since.
Wow, that's really cool.
It's kind of really cool to see someone in their craft doing what they love, and then you just can't help but fall in love with it.
Yeah.
So we also like to ask, what is your athletic training muse? And this is a modality, rehab tool, tape, brace, etc. Honestly, any tool of the trade that represents you as a clinician.
I was really excited about this one. I have been listening to your podcast since 2020 when you guys really first started. And this was a question that I spent a lot of time thinking about because I wanted to do something that was kind of different and something that I have in my kit that I use all the time. And it really came down to BioFreeze. And the reason why is I think BioFreeze represents me is because I can get you started on your path to healing, but I'm not a permanent fix.
Oh, okay.
So you kind of have to put in the work. Like I can temporarily make you feel better, but you have to put in your own work in order to feel better and do your rehab.
I love that. And the reason why is because I feel like so many times that we talk about how important we are in the process, and absolutely we are so important in the process. But we also have to remember who we're doing this for.
Yeah.
And that really shows me how much you're patient-centered.
Thank you.
I'd say what I love is we've been doing how many interviews? And like, to be honest, we've only had like every one has been a different answer except maybe like 3 or 4.
Right.
Like that's cool. I don't think we've had BioFreeze.
I know, we've never had BioFreeze.
I like that one. That's cool.
Yeah, BioFreeze, any sort of topical analgesic that that just makes people feel better for a short amount of time.
And also important to the process.
It is.
Yes.
So with that, let's kick it off with a story, as we like to do here on AT Corner is stories, obviously. Any story, experience, or a case study, something that kind of kicks us off, talking about how pelvic tilt has made an impact in the treatment of someone you've worked with.
So when I thought about this, I went way back to my first interaction with a patient who had pelvic tilt. One of my athletes that I observed under in high school when I was working under Maria, she was a volleyball player who always landed on her left side while serving. Mm-hmm. And no joke, like that repeated motion, we checked her leg length discrepancy and she was about 4 to 5 inches longer on one side.
That is significant.
So significant difference. It's probably one of the most significant cases I've ever seen. Mm-hmm. So that really kind of got me interested in it. And I also have pelvic tilt myself, so I know what the symptoms feel like, and I know how it feels when I have an athlete that's experiencing these symptoms. So I also know how to treat it.
Yeah, for sure.
No, that makes a lot of sense. And you're talking about an anatomical leg length, or are you talking about functional?
The functional leg length, so muscle imbalance leg length discrepancy, not an actual anatomical leg length discrepancy. And this was inches, not centimeters.
Yeah,
wow.
For sure.
Wow.
Man, that is pretty significant. That's almost half a foot.
Actually, yeah.
Yeah, when you really think about it. So once you guys kind of like notice that, like how quickly were you able to like resolve some of those symptoms? Like how many sessions, or like was it a pretty quick fix, or did it take a little bit of time? If you remember.
Yeah, she was a tough one. I remember it being a very chronic kind of treatment regimen. It was like she was coming in every day. We were doing muscle energy. We were doing exercises, and she would go to practice. And then after practice, she would come out like she would honestly come in. I remember her being pretty emotional because it was just so painful. So I remember doing a lot of treatment work with her, and Maria let us do a good amount of stuff with her too as students. So that was pretty cool. We got to work with her, and I was pretty young back then. So it was a good experience, but I definitely felt bad that we couldn't do more for her.
Of course.
Do you know if because I had someone who immediately when you were talking about that, I had a dancer who was very familiar in that sort of case, but she also on top of that had a trochanteric bursitis, like right over that greater trochanter, because of her lateral pelvic tilt and how she kept sitting in her hip. So I don't know if this is something, because you've seen it a lot more, if this is something more common that you've seen, or if it's not as common.
No, I definitely think that, I mean, it makes sense with the anatomy, right? That IT band is so tight and it's pulling you down, pulling that, that iliac crest down. So I would definitely say that's a possibility. I'm sure that that's something to think of clinically, right? So I think going forward, that's definitely something that clinicians should evaluate for and consider in their differential.
Absolutely. And that was one thing that we had to keep treating her on top of fixing the postural, but also treating the symptoms of everything happening post-bursitis.
Right. All that inflammation control is going to be really important with that.
Oh, absolutely.
So just so we can all get on the same page, can you help us define what exactly pelvic tilt is?
See, I was just going to say we set it up perfectly by saying anatomy. This is the anatomy of the interview. We're getting to the bones of the topic.
This is the anatomy for you, Randy. This is your favorite part. So we'll get right into it. So pelvic tilt refers to kind of that spatial motion or position of the pelvis in that frontal horizontal axis. That's for anterior pelvic tilt, right? And then it's primarily referred to in research as that sagittal anterior posterior pelvic tilt too. So there's that frontal lateral pelvic tilt, and then there's that anterior posterior tilt in the sagittal plane. So you kind of have to think about the planes of motion in regard to that definition. And then there's also like other definitions that I've come across too, where anterior pelvic tilt has been defined as that ASIS being lower than the PSIS in that sagittal plane, where the psoas and the quads and the erector spinae pull the pelvis into anterior tipping, causing a hyperlordotic curve in that lumbar spine. So that's kind of that lower cross syndrome that we refer to as weak abdominals, glutes, hyperactive extensors, and a hyperactive iliopsoas as well. So posterior pelvic tilt is defined as that PSIS being lower than the ASIS in that sagittal plane. This is the least common version of pelvic tilt, and really what we're striving for with most of our pelvic tilt patients is that anterior tilt. So we're trying to put them in posterior pelvic tilt to kind of get them into that neutral pelvis, but posterior pelvic tilt does happen, and it's caused by the hyperactivity of hamstrings, glutes, and abdominals. So really the opposite of what we just talked about. The other thing that is involved is a taut iliofemoral ligament. When you do think about the anatomy, that is pulling on the pelvis posteriorly. So really the rectus abdominis and the external obliques are the more hyperactive abdominals in this situation. And then lateral pelvic tilt is defined as the ASIS and PSIS on the ipsilateral side being lower than the contralateral ASIS and PSIS in the frontal plane. So one side is higher than the other. That pelvis shifts laterally in the frontal plane due to hyperactivity of that quadratus lumborum, glute med, TFL, and adductor longus and magnus on the ipsilateral side. So that's usually the symptomatic side as well.
And we're talking strict posture. We're not talking about functional pelvic tilt like during a squat. You know how some people can go into an excess lordotic curve due to an anterior pelvic tilt, or at the bottom they have like that winking where they have the posterior pelvic tilt. We're strictly talking about postural, correct?
This is postural, and it can be functional. So when you think about it, that pelvic tilt does really affect gait, and we'll kind of get into that in later on. But when you have that postural pelvic tilt, it really affects everything functionally. So it is postural, right? So we have to address the postural problem first, and then we can kind of get into that functional aspect of it.
So tying into that kind of functional aspect, what are some of those complications from having an excessive pelvic tilt, whether it's starting with the postural deficit or even noticing it in a functional aspect?
Absolutely. So some of the complications of having that excessive pelvic tilt, whether it's anterior, posterior, or lateral, are acute and chronic muscle imbalances. They impact body mechanics, just like I just said. And it also impacts ADLs, right, and gait. So those are kind of the three main things for just typical, patients, not necessarily athletes, but anybody that has pelvic tilt. And then also when you think about anterior tilt specifically, it does decrease the available range of motion at the hip. So when you are in anterior tilt, you do not have the same amount of available range of motion as you would in neutral pelvis.
Yeah, that makes sense.
Another complication could be increase in symptomatic hip conditions. So this has been found in research with significant pelvic tilt differences. It can initiate impingement at the hip joint, which can exacerbate symptoms of hip impingement. Just that like femoral hip impingement, any sort of FAI situation can exacerbate due to pelvic tilt. And then in sport, this can impact performance and it can cause pain during sport. It's extremely unlikely that low back pain is only a muscle strain. Pelvic tilt is really often missed and looked over, especially in women. Female patients do lack that attention in that sense. So it's really important to consider that as kind of a a factor as a clinician, is to really take a look at that with your female athletes especially. And patients really lack success without consistent treatment and rehab. So that's another complicating factor.
Yeah, what I was going to say, back to like the female patients, I mean, it's just from a research side, like, you know, a lot of research just in general tends to be more like male athletes or male students. So like it would be interesting to kind of see, okay, how does that differ now?
That's exactly what I found. I found very few studies on just female athletes. So I think that would be a direction to kind of look forward to with my research.
For sure.
I'm going to keep going back to the dance world because, well, one, because that's where I started out, but also the incidence of pelvic tilt, especially when you're talking about dancers and when you're talking about lack of hip range of motion, it's a big topic because especially when you're looking at like a ballet population, they have to get extreme ranges of motion in their hips. And a lot of times they do lack some stability in functional stability. Even if they have a very strong core, it could just be lengthened due to the excessive extension of their backs that they need and excess other motions. And so you're seeing a lot of times if you're able to get functionally, if you're able to get their pelvic tilt into a more neutral position, you are able to get more hip range of motion, which is desired.
Absolutely. I think especially with dance too, I think the expectation is that they have that hyperlordotic curve, but in reality, you need to have that neutral pelvis in order to get the range of motion to do, you know, kicking motions or pointing the feet, whatever you need to be doing. And it does affect the motion at the knee and the ankle too. We can't forget about that. So really, it all starts in the hips and the pelvis, and treating that first is super essential.
So it's actually really interesting because I feel like this is a very popular topic in the performing arts world. But I love actually when you brought this up about the sports world, because I feel like it is not very much a touched upon topic, nor is it research. There's a lot more research, I think, in performing arts med than there is in the sports world. So actually, could you tell us how you brought your screening process to a more sport specific, like a traditional sport specific setting?
Absolutely. So, my last job was at a boarding school in New Hampshire, and it was a small school, about 300 kids, and we had a strength and conditioning program for the athletes who were not in a sport. The school was required to play 3 sports, so every student had to play 3 sports.
Wow.
Yeah, so if a student had 2 varsity sports, they were allowed to do strength and conditioning with our strength and conditioning coach. And she and I collaborated on a screening process for that strength and conditioning group because she was interested in pelvic tilt and seeing how it affected the biomechanics of all the kids that were in strength and conditioning. So we started this screening process, and I'll kind of go through and explain that in a team sense. And then I'll talk about individual screening as well. So I guess I'll begin with the individual screening process. It all begins with observation. So watching the patient's gait. How do they sit on the table? Do they favor one side? Does an athlete have a repetitive motion that may be involved? Kind of knowing your athletes and knowing their history and observing how they function is really important in this evaluation process. So that's step 1. Step 2 is ruling out any other cause of low back pain, adductor pain, glute pain, ruling out facet, disc, any other spine pathology. And then looking at the visual would be the first place that I start. So looking at anterior, posterior, lateral pelvic tilt, having the patient supine on a table with their legs extended. Clinicians kind of hook their thumbs just under the ASIS, and then I use my dominant eye. So I close my dominant eye is my right eye. So I close my left eye and I open my right eye and I visualize looking at the ASIS height. If the thumbs are equal, then they're usually pretty good, but I still do move on to the next step. If they're uneven, then I know I'm guaranteed to move on through the evaluation process. So doing the sit-up leg length discrepancy test is my first go-to. Hooking the thumbs under the medial malleolus, instructing my patient to do a glute bridge in order to neutralize the pelvis on the table.
Mm-hmm.
Then I instruct the patient to perform a sit-up and relax and extend their knees and their legs. So as the patient kind of pulls their legs into extension, you give a little gentle traction. And then you use that same thumb visualization to see if there's any discrepancy or apparent leg length. And also knowing that if your student has an anatomical leg length discrepancy versus a functional or postural leg length discrepancy is really important.
Mm-hmm.
So that shorter side is often the symptomatic side. So I didn't really talk about signs and symptoms of pelvic tilt, but that pinching is the most common complaint.
Mm-hmm.
And then always after I do that sit-up leg length discrepancy test, I go back and I look at the ASIS height as well. So I go back to the hips. That's really important, checking the pelvic height at the ASIS and the iliac crest. So I'll kind of take two thumbs, put them on the ASIS, right under it, hook under, and then I'll take the rest of my hand and make like a C shape with my hands and my fingers, and I'll put that C shape right on the top of the iliac crest so I can kind of visualize and see the pelvis.
Nice. For the pinching sensation, have you noticed is there a particular level that they tend to feel that pinching, or could it just be kind of variable?
Typically it's right over the SI joint.
That's what I was thinking. Perfect.
But also patients' other signs and symptoms of pelvic tilt are that pinching feeling right over the PSIS or SI joint. Sometimes they do have really tight or spasmed glutes or QLs. So that quadratus lumborum and those glutes, often very tight and tender. Often radiating groin pain is another symptom that I've found on that ipsilateral side. So radiating groin pain down on the symptomatic side. And then low back pain, tight glutes unilaterally, and then difficulty or pain with rotation, flexion, or extension of the lumbar spine, in active range of motion. And then painful hip extension is also a common one. And then one that I've noticed with hip range of motion assessment is lack of internal rotation on the affected side.
You know, it's crazy to think, without how much of an emphasis we put on pelvic tilt in a traditional sport sense, how much it actually is affecting so many other things, because the pelvis is really the connection between lower body and torso. And because we spend most of our time, unless you're a gymnast, on your feet, you know, everything that we're doing is impacted and going up and down that chain. So even when I was working with a soccer athlete, and he was dealing with recurrent hamstring strains, and it came down to when I had looked at his ratio of or his movement pattern, he was firing glutes way late. He was firing his erector spinae very. He was like over firing his erector spinae, and it was actually sending him into an anterior pelvic tilt while he was doing a hamstring curl, which was really interesting because you think the hamstring should be actually doing a hip extension moment. It shouldn't. If you're doing an anterior pelvic tilt, then you are actually lengthening that hamstring, and that is not optimal for that muscle to be activating. So if you think of all these things that the pelvic tilt can affect, not just at the level itself, but up and down that chain.
Sounds like a biomechanical mess there.
Yeah.
Yeah.
When I saw
that, good way to describe it right there.
All right, we've got a long way to go.
Well, shoot, you see that with sprinters all the time too, right? They tend to start to develop an anterior tilt. Well, they have to have such extreme ranges of motion, especially for their knee drive and to hip flexion. Well, if you're already pre-stretching the hamstrings beforehand and you throw them in that huge range of motion, that's where problems happen.
Right.
Absolutely.
How we described it, biomechanical mess.
Biomechanical mess. So I guess let me go into evaluation process for a team sport.
Yeah, that'd be
Please,
great.
yeah.
And we'll kind of go through what I did with 25 kids by myself. So it's very doable. And honestly, I think the easiest way to do it is have somebody be your scribe.
Okay.
So I made this chart, and then I had my strength and conditioning coach was my scribe, and I went through the entire evaluation process with every kid, and we did it all in like, I think it took us a half hour to go through 25 kids. And as we were going through the evaluation process, I was also treating them. So every kid walked out of that evaluation in pelvic neutral.
Nice.
Okay.
That's really cool.
Yeah, basically clean slate. Get them all on the same page and somewhere for them to start.
Yeah, so they all got to start their workout that day in pelvic neutral, and some of them stayed in pelvic neutral, but none of them really did because it's just such a postural thing, right? You have to consistently do rehab and treatment and fix it. So that's kind of the process that we'll go into next, is that treatment. But the screening process, I had the athlete's name written down. I did every kid, I would start with the sit-up leg length discrepancy test, and I would write positive or negative. And the shorter side, I would write, so if the right side was shorter with the leg length discrepancy, I would write positive right side. And then I would look at hip range of motion. So I would look at internal and external rotation specifically. And then I would write down, kind of visualize, guess like, okay, they had 40 degrees of internal rotation on the right side, but the left side, they had 30. So that might be their symptomatic side because they have decreased internal rotation. Then I didn't talk about this one yet, but I would do a PSIS, anterior posterior mobilization movement. So I would do kind of that anterior posterior mob on the PSIS and assess how that pelvis moves. And one side, usually the symptomatic side, feels kind of stuck. When you go to do that mob, you do not get the same motion. Really putting kind of the heel of my hand on that PSIS and doing some mobs. And I write down the side that gets stuck. Then I write down if they have visualized, if I see anterior tilt, posterior tilt, lateral tilt, and then I write any special notes, like if that athlete had a previous hip flexor strain or how long they've had symptoms for. So that was the screening process. That was it.
That's still pretty cool, man. 30 minutes to bang that out. That's pretty cool.
It's very quick. When you go right through it and you do every kid back to back, you can get through it pretty fast.
How was the communication with the strength coach? Like, did you both kind of come up with that idea, or did you kind of present it to your strength coach? It was like, hey, here's what we should consider.
So actually, my strength coach presented it to me
that's cool.
and was like, hey, is there any way we can do some sort of biomechanical testing? Like, I know you're really interested in pelvic tilt, and I know we have a few athletes that are doing strength and conditioning that you're already treating for it. Is there a way to kind of screen everyone else to see if they have it? And she was like, I don't want this to take too much of your time. So we spent a good couple weeks trying to come up with this screening process. And we didn't meet every day, but meeting over the course of a couple weeks, like once, twice, 3 times, just talking about what we could do and how we could make it a smooth process and not disturb too much of the time from the strength and conditioning program, as well as my time in the athletic training room. So
nice. That's cool. That's awesome that your strength coach kind of presented it too. I like that.
Oh yeah, she rocks.
It's also like, if you think about, we already implement baseline concussion testing, and we implement baseline other, or even just time to do like our sportswear or whatever EMR you're using, like to implement some sort of injury prevention program or implement something that you are finding is across the board something necessary for your athletes. It's very valuable and it's accessible.
Imagine if they had part of the EMR that you were using was this pelvic tilt screening process. Imagine if that was already built in.
See, that, I mean, kind of off topic of where we're going, but I think that's one thing that I think, at least for our EMRs, and I haven't seen all of them that ATs use, but I feel like that's the limiting factor. I feel like there's stuff on there or stuff that's not on there.
So there is actually, this was somewhere where I worked, we had a personalized EMR that the company had put together for us. And it sounds really cool, and I wish I could be on board. It was really cool. It had some kinks.
Of course.
And,
as with any EMR.
Right. That made it a little tough to work with. But what was really cool was because of the system that we had in place, essentially every single athlete who would come in, every time that they were hired, we would take them and they would have a session with us, and we would run them through an assessment, various assessments. I didn't make up the assessments, someone else did, but basically the whole entire company had these assessments that we would run through. There were screens. We would look at squats. We would look at lunges. We'd look at planks. We'd look at a Y, shoulder Ys, things like that. And we would grade them and assess if they need scapular stability, or if they need to address their pelvic tilt or stuff like that. And we would put that in the EMR. And it was set up so that it would, each screen had scoring, and then also had comments. And then from there, we would create, or depending on what their score was, they would get a certain number of sessions with us. So if they scored really well, they would only get 2 sessions. And this was just strictly for prevention. And then if they scored more poorly, they'd get up to 8 or more sessions with us that were just basically for injury prevention. And then what we would do is we would assess okay, we have to address our pelvic tilt, and then we would go into treatment options. So actually, speaking of, that is actually a perfect segue into, can we address some of these treatment solutions?
Okay.
That's really cool that you did that and had that software.
But you see, you had to get it had to be personally developed.
Yeah, it was personally developed.
That's the thing.
It took years for it to get to what we asked for. And then still, even then, it was there was a blockage between us and the person who was communicating with the person who made it. So it was 3 degrees of separation, rather than hey, can we change this? And then years later, they would change it.
But yeah, that's the thing. I wish more EMRs had built-in systems like that, even from a patient-reported outcomes standpoint. We talk about how important that is, but yet none of the EMRs we use,
not a single one,
necessarily has it built in
for PROs.
So it's interesting. Sorry, that was an interesting tangent.
I think it will change because our generation's more tech. I think.
Yes, I think so. We'll get there.
Anyway,
That's really cool. It told you the amount of sessions that you had with the athlete if you needed to address any of those issues.
That's pretty cool.
So therapeutic interventions to address pelvic tilt. Treatment-wise, typically I start with muscle energy, starting by stretching the iliopsoas bilaterally, split stretch on the table if they can tolerate that, getting them in a crunch to kind of decrease that lordotic curve. Getting their lumbar spine flat on the table is essential. And then I stretch the psoas first. Then I do that push-pull technique for muscle energy, activating the anterior and posterior muscles to correct that lateral tilt. Having the patient supine with the knees and hips at 90-90, instructing that patient to push isometrically, either with their hand or a stick or PVC pipe or against me. And then activating that hip flexor on the affected side and the glute on the opposite side. On the non-affected side, having the patient pull, activating that posterior chain. So that push-pull technique can be done for 10 seconds, 2 to 3 reps. And then I usually couple that with the adductor-abductor muscle energy technique, having the patient supine, hook-lying position, have the patient squeeze either the clinician's elbow, a ball, foam roller in between their knees, and then same thing, pushing out either against the clinician's arms, a band, a wall, a table, and that can also be done for 10 seconds, 1 to 2 reps. And then stretching that internal rotator on the affected side, typically stretching the affected side only. It helps realign that pelvis when muscle energy techniques don't work by themselves.
Nice. That's really cool.
That's typically what I do for just acute. And then obviously the chronic patients I have do rehab.
What sorts of things are you focusing on in rehab?
So rehab corrective exercises for pelvic tilt, depending on the patient. So it really depends on muscle weaknesses / imbalances, really hyperactive muscles as well. So really assessing what that patient needs is important, and then tailoring their rehab towards that. Nice. So corrective exercises I typically use are hip hikes, glute bridges, quadruped fire hydrants, cat cows. I do seated internal and external rotation of the hip with the band. And then I'll also do side leg raises for abductors and adductors, single leg glute bridges, really emphasizing that pelvic tilt. So I'll do a glute bridge, instruct them to get into that posterior pelvic tilt, and then fire the muscles. And then anything else for core stabilization as well.
Nice.
You know, I feel like there was a big emphasis. It's almost like like in waves. Like there was big emphasis on kind of those like, I don't want to say simple, but like the, you know, our basic fundamental exercises of like the glute bridges and the clamshells and kind of stuff like that. And then we kind of went away from it, and we have gotten a lot more like full body. And I think we're kind of getting back into now. We need the fundamentals. There's a reason you're not hitting these in the strength lab. A lot of times you're doing the big motions and you're lacking the hip strength because you're not doing things like clamshells or side laying leg hip abduction or stuff like that.
For sure. So that's a lot of the stuff like the manual therapy and the rehab that you're doing with them. Is there anything else that you would have the patient focus on them, like by themselves, like when they're, you know, at home, or like, you know, when they move on to maybe like a different level and that they can do stuff on their own?
So I would separate it by where the patient's at in their phase of care. So if they're in that acute phase, I'm instructing them on how to do these muscle energy techniques on their own. So when I'm not there, they can still neutralize their pelvis and figure out how they're out and which way they need to kind of neutralize their pelvis and what muscle imbalance they're having and how to fix it. And then as they start to recover, I individualize those exercises and have them do them on their own. So in the acute phase, I'm really watching them and I'm watching their mechanics. And then as they start to become less symptomatic, I kind of send them off on their own and see how they do. And if they start to come back complaining of more symptoms, then I'll go back and reevaluate.
I like how you started with the education piece, because really the more that you are able to get them to understand, the more that they're able to buy in and actually start to work on this chronic issue that it's not going to fix itself overnight. I always tell people, like, it didn't happen overnight, so it's not going to fix itself overnight. Also, we didn't even touch upon the fact how if they're getting more familiar with where neutral is for themselves, that can also affect like where their rib cage is in space and how they're standing posturally and walking through, sitting in class, whatever they're doing with the rest of their day.
Yeah. Sure.
Absolutely. Currently at my new job, I'm working with pre and postnatal pelvic floor patients.
Nice.
And this is a huge component of rehab. So patients that are hypertonic in their pelvic floor, we're working on activating that transverse abdominis, especially postnatally, because that core has been split open. Yeah. And often these patients have rectus diastasis, where their rectus abdominis splits and they have nothing left because the baby has just shredded their insides.
Right. Yeah.
So essentially that's what we're working on is getting those deep core muscles to turn on again. And I often bring in that diaphragmatic breathing too, and bringing the rib cage towards the pelvis and cueing the patient to bring their belly button closer to their rib cage and push up against my fingers, and I'll give them that manual biofeedback as well.
Nice.
And that's huge because your diaphragmatic breathing can change based on where, if you're not in neutral pelvis either. Because that whole core is working with the transverse abdominis and the pelvic floor, and the top of that is the diaphragm. So it just all makes sense that it's all connected.
It really is. And the other thing too is that when you have these patients who don't understand where their pelvis is, when you explain to them, oftentimes they're confused at first, like, whoa, this is a lot. And then once they start to get it, they get it. And then you can start working in different planes of motion. So I'll have them do it on a Swiss ball, or have them do it standing, or often one of the best exercises I've found for getting patients to get in that posterior pelvic tilt is having them against the wall and doing a squat with a yoga ball behind them.
Nice.
Because the yoga ball keeps them out of that hyperlordotic curve. So it allows them to tilt that pelvis posteriorly if they can't get it supine or standing or seated.
Nice. That's cool.
That's really awesome, that population you're working with now.
It's a really cool job for sure. Very, very different than working with high-level endurance athletes or young people. It's a very different population, but it's all people that have the same problems, right? So like people that have pelvic tilt could be 14 years old, or they could be 30 and postnatal.
Right.
So it kind of shows how widely needed that the education is on this topic.
That did actually remind me about a question that I was thinking of earlier. You know, a lot of the pelvic tilt evaluation starts with them on the table, right? With them being supine, prone. Do you also add in a component where they are weight bearing, and have you liked one set of results or one set of evaluation better? Like, do you like them weight bearing because it's more functional, or do you prefer them on the table?
Absolutely. So I think the weight bearing evaluation, which we didn't even touch on, typically I'll have patients standing, and when they're standing, I can look at that PSIS height. So I'll kind of get behind them and get eye level to that PSIS. And oftentimes I'll have them cross their arms and then have them do a few hip flexion exercises, right? So I'll get their hip flexors and their knee to 90-90 and have them bring it up actively to see if their PSIS moves. So that's more of a functional weight-bearing assessment to see if that patient can keep their PSIS level and activate that transverse abdominis in order to keep it level. And you can kind of notice, you can look, what do you see? Is there a noticeable tilt? Is one side more difficult or stiffer to move than the other?
Yeah, that's awesome.
Yeah, that's awesome. That's good.
There's really a lot of transfer that happens from that you can get from both evaluations.
Yeah, for sure.
Sweet.
Yeah, and even with that evaluation too, having the patient bring one leg up at a time and kind of having them march in a sense and looking to see if I'll be like, okay, lift your right leg, lift your left leg. Oh, lift your left leg again, and kind of switch it up on them to see if they can hold that TA contraction.
Nice.
Yeah, because you also tell if they're already shifting their weight to go to the other side.
It does eliminate the cheating. You have to keep them on their toes.
Yeah, they do it to me, man. They keep us on our toes. So might as well give it back to them.
They do.
I got you on that one.
Oh, yes.
My favorite is, again, another segue. A lot of segues, or tangents on this one. When they try to predict what exercises I'm trying to do, they'll be like, I know what's next. I'm like, no, you don't. I'm like, yeah, I do. I'm like, no, you don't. And then I'll do something like, oh, I didn't know that. I'm like, yeah, I see you didn't know.
Yeah, throw in the yoga ball on them next time, and they'll have no idea what to do.
100%. 100%.
That actually, what you were talking about, that where you have them seated on the yoga ball and you're just like, if you have their hands on their hips and just like marching there, that is the biggest, like, I think it's the biggest eye opener that I see for like my traditional sport athletes when I have them sit on the ball and they're like, oh, I can't do this.
Your big old football guys can't do it.
That real deep core stabilization is really hard for a lot of people.
It is. All right.
Is it time?
I think it's time. I think it's time for some action. So, go ahead. No, you were ready.
No, I wasn't ready.
Oh, okay, not ready. but we are ready for action. So as we like to end with all of our interviews, this is Sandra's one of her favorite aspects of the interview episodes is an action item, something that, the clinician or the student listening can take this and like, boom, I'm ready to hit the ground running. So when should the athletic trainer evaluate for pelvic tilt?
So I like to separate this into two categories, individual and group. So individual patients that are reporting symptoms or a clinician has ruled out any other diagnoses, this is when to evaluate for pelvic tilt. And then team sports or small groups of athletes, usually 20, 25 athletes or less is manageable from my experience. Doing this by myself and having a scribe write down notes for my documentation later on. This is when a clinician can kind of apply it to a small group.
Nice.
I think that was one of the biggest things I was excited about for this episode was talking about how you've already implemented this. Yeah. It's not just theory, that this is actual actionable things that clinicians and that you have already put into play.
Thank you. Yeah, it's been a fun process and a lot of learning and a lot of bumps in the road, but I think it was overall pretty successful watching the patients progress over, week by week. We would reevaluate every 2 weeks, and seeing the patients graduate essentially from our pelvic tilt rehab protocol in strength and conditioning was pretty amazing.
That's cool. That's awesome. So I think it goes back to what we talked about as we were going into the intro of the interview, is just how actionable, like 30 minutes for a screen. Like you always leave like a session or a talk that talks about implementing a screening process, and you can leave away thinking like, man, how am I going to do that? Like
it's faster than concussion baselining.
Yeah. Right. And here's someone who basically by herself, and like, yes, she was saying she had her strength coach to help scribe, but it's one clinician doing it and got it done in 30 minutes. Like that's something that like, shoot, like I can leave this, be like, hey, that's something I can do. I'm by myself. I have 30 minutes. I could do this. So I thought that was very, very clinician friendly. I feel like it's very something that you can just take away right away. Also,
the fact that we're talking about working with strength coaches and whoever you have with you is really awesome to get that. What's the word I'm looking for?
That like
interprofessional health.
Oh, that's a big buzzword nowadays. Interprofessional care.
Yeah, interprofessional care.
Yeah, but no, that's true. And again, it just highlights, dude, strength coaches are on it too, man. If you have a strength coach, it's a game changer.
Yeah, it really is. So if you guys are new, we do lots of different types of episodes. We have story episodes, which we have real life athletic trainers submitting their stories of their experiences on various topics. We have interview episodes just like this one. We have education episodes, which are also paired with some CEUs, thanks to Athletic Training Chat.
Yes, big time.
And Clinically Pressed. They're super awesome. They're helping us switch over providers. So thank you guys for being patient with us as
Very
we're
grateful.
Adding more and more CEUs throughout the year. So make sure you check that out. If you're interested in joining a Facebook group where you can talk to other listeners of the show, kind of comment on this podcast, it's facebook.com/group/AT Corner Podcast. There's only one question to get in. Where did you hear about this podcast? And then it'll automatically let you in and join in on the fun. Everything else is in the show notes. So without me trying to bore you at the end of this, just head on down to the show notes or the description wherever you're listening on YouTube or your whatever podcast directory. And I think that's all I have.
Thank you for helping us showcase athletic training behind the tape. Bye.